Good afternoon, and welcome back to Health Leaders The Winning Edge program, a series of webinars touching on the topics and strategies that you need to know most. My name is Chris Cheney. I am the CMO editor for Health Leaders and will serve as your moderator for this session. Today's webinar is titled The Winning Edge for Keeping Your Physicians Happy. Thank you to you and our audience for participating. Before we get started, for those of you participating in the live program, I have a few housekeeping details. Note that an on-demand version of this program will be available on our YouTube channel on Friday and can be accessed through our website, healthleadersmedia.com. To ensure that you can see all content for the event, please maximize your event window and be sure to adjust your computer volume settings and/or PC speakers for optimal sound quality. Next, you will find a resources list for today's webinar on the upper right side of your screen. Here we have listed the webinar slide deck and some additional materials for you to download, along with the registration link for future Winning Edge events. At the bottom of your console are multiple widgets you can use. To submit a question, click on the Q&A widget. It may be open already and appear on the left side of your screen. You may submit questions at any time during the presentation. However, please note that it is likely that your questions will not be answered until the Q&A portion of the program. Finally, should you experience any technical difficulties during today's program and need assistance, please click on the Help widget, which has a question mark icon and covers common technical issues. At this time, it is my pleasure to introduce our featured panelists for today's discussion. Dr. Thomas Campbell, Chief Wellness Officer, Allegheny Health Network. Dr. Susanna Fox, Executive Vice President and Chief Physician Officer at Advocate Health. And Dr. Tricia James, Director of Clinical Experience at Providence, Oregon. Thank you all for joining us. And with that, let's get into our discussion. First, tell us a little bit about yourself and your organization. And Tom, why don't you start out?
Yeah, thanks, Chris. I'm an emergency medicine physician by training. I have been practicing for 37 years, so I'm really in the far end of my experience as a physician. And I work at Allegheny Health Network, where I have worked for 36 of those 37 years. So a long time in the organization. Allegheny Health Network is in Pittsburgh, Pennsylvania. We have 14 hospitals, and we've had a wellness program with a position for Chief Wellness Officer for the past 8 years. And it's a privilege for me to be here.
Tricia?
Good morning. Thanks for having me. My name is Tricia James. I'm an internal medicine physician by training, and have also spent a lot of my career in education and continue to be a faculty member in a residency program. My other title and why I'm here today is I'm Director of Clinician Experience for Providence in Oregon. And we're a relatively new department. Our organization, so Providence, actually spans 7 states total, but has a large footprint in Oregon. As a community hospital system, we have 8 hospitals in Oregon, and also a medical group that with many clinic sites throughout the state as well.
Excellent. And I'll have Susanna go next. And just a note to the audience, Susanna had to call in on her phone. Her video isn't working. So Susanna, tell us a little bit about yourself and organization.
And firstly, I do want to apologize for the technical difficulties today. So, Susanna Fox, I am an OBGYN physician by training, work for Advocate Health, which is the 3rd largest non-for-profit healthcare system in the nation. We span 6 states across North Carolina and Georgia, and Illinois and Wisconsin, as well as Michigan and Alabama. I lead the Best Place to Care initiative for our entire organization, which is really our wellness and engagement initiative for our physicians and APPs. Just to give you an idea of the scope and scale of our physicians, we employ over 22,000 physicians and an equal number of APPs.
Excellent. Let's get into our discussion. How can AI tools help physicians to reduce administrative burdens and address other contributors to burnout? And Tom, why don't you start us off?
Sure. Thanks. I think AI as a tool has been really helpful for especially the efficiency domain of physician work. It's created an efficient practice for physicians to document within the electronic health record. And because of that efficiency has created much more time management so that physicians can use the time to either plan for their personal life or for the other things they like to do within their practice, whether that's academics, research, and all. So I think the most obvious thing at the beginning was that the AI use within our electronic health record has really created some efficiencies and given back time for physicians to spend in their practice with their patients, but also to do the other things that keep them well and engaged. And I'll let some of my colleagues who are on talk about some other things that AI can do with to help us out.
Trisha?
Yeah, I love what Tom said, would echo a lot of that. And I just want to name specifically one of the things that I see around the potentials of AI and giving back time is it allowing us to focus on the areas of care where we find more meaning and therefore can decrease some of the burnout that we're finding. So a lot of what I've heard is around, yes, it saves me a little bit of time, but really at large, it allows me to focus on the patient in front of me differently. And I get a different sense of kind of meaning from that interaction. And or how are we allowing for time to continue to learn with our teams and think about things like team dynamics, et cetera. And I'm really hopeful that in the coming years, AI is going to get even better at helping us with some of the logistics of navigating care and pulling in pertinent information and things like that I haven't seen yet, but I'm very hopeful are coming soon.
And Susanna?
Yeah, just to add, I love what the others have said, but like Tom, I have been in medicine for 35 years, and what it looks like today looks nothing like it does from a technology standpoint. And so really making sure as we implement these AI tools to really help our physicians and APPs to reduce administrative burdens and address burnout, we really want to make sure that we're intentional about choosing the tools that absolutely gets them to be doing what they went into medicine to begin with, which is to look at patients in the eyes, to ensure that we spend time with our patients, that we have the connection with them. So I think, there's the amount of clerical work that we have, given to our physicians and APPs across our enterprise is huge. And so what we really want to do is make sure that we, give them all the tools they need for documentation, inbox triage, chart navigation, those types of things, so that, physicians can do what they really went into medicine to do. And the only thing that I would say, and I think it goes without saying, but I'll say it anyway, none of these AI tools are meant to be used in the absence of human oversight. So, we have a very robust framework that we use to vet and validate the use of AI in our organization. AI will absolutely not replace the human factor of medicine, but I think it will augment it, and so we are better together.
And can one of you give specific examples of AI tools that you're using to help physicians?
Yes, I can start. So for all of our 22,000 physicians, they have access to Dragon Copilot, which really allows this ambient listening, allows our, and we've actually expanded it to nursing too, but for the physician, cohorts, they go in, set down their mobile phone, and then a note is created for them. Obviously, it needs to be reviewed, but at the end of the visit, there's a visit summary to the clinician's device for reviewing and editing, and this has really helped with physicians making eye contact with patients, obviously, instead of looking and clicking at a computer. We've also recently developed and added new AI features to analyze charting and to generate comprehensive summaries of care. And we've been doing that not only in the ambulatory space, but in the inpatient space. And one thing that I love that we are getting great reviews for is as patients come in, we know that a lot of time they've been seen in many different hospitals. They have very complex medical histories, and we have an AI tool that creates a discharge summary for our physicians and APPs that saves an inordinate amount of time for them having to go through the chart, which has really gone over really, really well with our physicians.
Anybody want to add to that before we move on?
Sure, Chris, it's Tom. One other technology we've been playing with, and we hear a lot about the MyChart inbox messaging and how that's led to a lot of burnout from just the number of messages that physicians, especially in primary care, get. And there's an AI technology that allows you to automate some responses to MyChart messages from the staff, and anything that can reduce the burden of MyChart messages is helpful. We've had some mixed responses from different areas that we are piloting the automated response technology with AI, but I have great hopes that it will help, and that will be another added benefit to some of that administrative burden that the whole staff, the whole team encounters in taking care of patients, especially within primary care.
Trisha, any other AI tools that you're using before we move on?
We are using similar tools, and I think I might just say, in addition to the time, and I'm thinking specifically about that in-basket message AI tool, and wondering, even if it doesn't save a lot of time, are we considering the impact on cognitive burden? So, and that's one of the things that I've heard is, I don't know that it saves an absolute amount of time, but it does allow me to have more cognitive space that I can then spend on something else that might be more satisfying or require that more intense level of focus and concentration. So I think there's yet to be decided in terms of like absolute impact, but that's one aspect I think paying attention to might be helpful.
I think, Trish, you bring a outstanding point, because when we look at the data, the amount of time that people spend in the medical record is not much less than what we would think it would be, but our physicians are much happier. They absolutely feel like that their burnout, their ability to do their work is much improved. And so even though sometimes the data does not tell us exactly, when we speak to our physicians and get feedback, they are saying it's one of the best things that we've ever offered to them.
Excellent. Let's move on. How can, and this is another technology question, how can you optimize the electronic health record to help physicians? And Tricia, why don't you start us off?
Yeah, so I mean, I think we've talked about this a little bit in terms of some of the AI tools and how they are integrated into the EHR, which is a big one that comes up for me initially. I think one of my hopes, and I would love to hear more from Suzanne actually about the summarization of complex records, which we have not had, but I think there's a lot of potential there as the EHRs have become so complex. It's an overwhelming amount of information for any person to kind of integrate, and then how do we find the pertinent pieces and move them forward? So I would love to see us continue that specific development as we go.
Susanna?
Yeah, to add to that, and Tricia, I would absolutely call it Epic Insights, which is what our, tool is to summarize charts. But we're also looking at standardizing care delivery. So one example is with diabetic, issues, especially with, foot ulcers and those types of things. It used to be 20 or 30 clicks within the EMR, and we've actually diminished it to like 4 or 5, which really improves the satisfaction of our physicians because, they don't have to, spend as much time clicking through. We've also, really introduced digital patient questionnaires that feed directly into the EHR so that, work outside of work, the time that physicians have to use to review charts either the night before or the morning of, we don't have to do that anymore. It's embedded into the chart, and it reduces that sort of cognitive load or training burden that we have. And in addition to what, Tom and Tricia have already said, we're also looking at exploring solutions to really reduce the amount of manual work needed on the high volume of emails in our physician and APP inboxes, looking at automating, reducing the manual workload, making sure that the right people are answering the right questions, having automatic refills where it makes a sense and is appropriate. So all of those are really impacting our physicians in a big way.
And Tom?
Yeah, I couldn't agree with both Suzanne and Tricia anymore, and especially with the cognitive load and anything we can do to assist the physicians with gathering the information from within the electronic health record where it all lives and gathers. But I think there's a unique, within the past week, my health system uses Epic for our electronic health record, and we had an upgrade. And another sort of interesting twist in this latest upgrade we put in is the gratuity hub. It's gratitude hub from a place to put in for the team to thank each other and show gratitude within the electronic health record where we live most of the day and are spent on, and hopefully in less time and more time with patients. But there's a nice way and a nice opportunity from within the gratitude hub in this electronic record to really thank someone for doing a special job, and even hopefully in future events, if it can connect to your patient experience where, if you're having a bad day, you can click onto the gratitude hub and say, a lot of what I'm doing is worthwhile when you're not feeling it. So I think another nice way for the electronic health record would be maybe to be able to show some of the gratitude from their coworkers, from patients, since we're in it all the time. And I think there was a nice effort from that electronic health record to try and do that. And again, we've only had it up and running for about a week, so I don't have much to tell you about it, but I thought it was a pretty unique way of looking at it.
Any other ways to optimize the EHR before we move on? Great. Let's go to the next question. How can you encourage a sense of community among physicians and boost physician engagement? And Susanna, why don't you start us off?
Yes, I tell you, this is probably the one thing that gets me up in the morning every single day. I think, our Best Place to Care initiative, which is really revolving around how do we best take the best care of our physicians and APPs so that they can in turn take the best care of our patients. There's a large body of work that needs to be done. Obviously, long gone are the days where, we saw our clinician colleagues in the hospital rounding because of the way, we function around, hospitalists. So we want to make sure that, we create a community intentionally through structured connections. We know, and my patients, knew this with me every time I saw them, right? If I have the support and resources that I needed and brought my best self to work, then I brought my best self to my patients and was able to really connect with them. And so with all the burdens that we've already talked about with the administrative tasks, I think how we bring support, resources, structured connections, improving, engagement with our physicians and their experiences, physician leadership and development, all of that is critically important. Not only does it help us recruit physicians, but it also helps us retain physicians. Those of us that have been in healthcare a really long time, and I know as I'm raising 3 millennials, there's a generational difference than those of us who went into medicine 3 decades ago than what are coming out now. And so we really want to evolve how we take care of our clinicians, make sure that we offer a flexible work environments, right? Make sure that, they have ownership and autonomy over the templates. Make sure that, if they are interested in, physician leadership, that we allow and have programs for that. I think the cornerstone of a lot of this is communication. I think, explaining the why behind things, why we are doing things or why we're not, making sure there's bidirectional communication so that the strategy can be informed. Very excited and very proud that, Advocate Health, has won the recognized as a Joint Medicine Gold Award from the American Medical Association. And that is just, a testament of the work that, myself and my team, you really wake up every single morning to make sure that the reason that our physicians and APPs went into medicine is honored. We give them, again, like I said, the tools that they need, and we give them a way to connect with each other. I love what you said, Tom, about recognition. Recognition is really important, and making sure that we do recognize them, and we also empower them to recognize each other.
Great, Tom.
Yeah, I like the question of community, Chris, because I think it's something we all strive to keep developing, and it's become much more difficult with the large size of you. As you heard, all of our organizations are very, very large, some multiple states. And so how do you develop a community? And I think my answer sounds simple, but it's not at all. And that's to be deliberate and to plan any ways that you can create community of the physicians. So, local dinners, communications, as Suzanne said, is critical. If you have an opportunity for two-way communication, but also community development, I've seen a lot of my local hospitals have reinvented the physician dining area and the physician rooms that sort of lost their way a long time ago for many reasons, but they've been redeveloped, and I found that to be very successful. Breakfast clubs, dinner clubs, any way to build community locally, and then bigger events, I think, when you have such large organizations, to really then use efforts in those large events to show gratitude, appreciation, and let people know they are valued. And then also to take that opportunity to try and share values so that the clinicians as well as leadership are on the same page or as close as they can be. And I think that we will always continue to struggle to keep finding ways to get community and engagement together with our clinicians. And but we have to keep doing it, and we'll find new ways, even if it's virtual book clubs and virtual dinners, and if people are that far apart in space. So I think they're all important. And when you feel like part of a community, it is so much better to work and you feel more supportive.
Trisha?
Yeah, I love what's already been said, and just to try and build on that a little bit, I think that the dining spaces, the events, are hugely important, and I wonder about also how we're using our embedded time together. And so most teams have a standard meeting at some frequency. and thinking about, are there opportunities within those shared spaces to build some community as well? And I appreciate there's some tension there with the pace of change and the administrative burden and all the things that we need to kind of do together. And I think there's some possibility to build community in those spaces as well. I love the Gratitude Hub, by the way. I'm totally going to look into that. And then I think to build a little bit on that autonomy piece. So I think this is one of the big challenges that I see is in really big systems, how do we get very clear in our infrastructure and our communication about the different degrees of autonomy? And so can we be really clear about, for any individual physician, what do they have autonomy over? At the team level, what do they have autonomy over? Can they decide their own best workflow for their unique setting and team, as an example? And then what are the things that really should be standardized or going to be helped by being standardized from a bigger perspective? And I see that there's an ongoing tension there of lack of clarity, first, of like, what do individuals and teams actually have autonomy over, and how can we give some autonomy back to them so that this continues to feel like this is their practice, right? And they can shape it and make it into something that they want it to be. And then the last thought I would have, just to kind of build on some of this shared values and really aligning commitments. And during this, now that we are in these huge organizations where the clinicians are increasingly separated from the business of medicine reality. And so I think sometimes we aren't necessarily articulating our shared commitments, and do we have those shared commitments? And so getting really clear about what are we prioritizing, and then how are we measuring that? What does that look like? And are we on the same page around what we're working towards? And I think as communities gotten eroded and things get so big and the disconnect between some of our clinicians and our leaders has grown, I see that as an ongoing challenge, but also an area of tremendous opportunity if we can figure that out.
Great. And circling back to Susanna, you mentioned structured connections. Give me some examples of creating structured connections.
So we have several. So first of all, we build community sort of intentionally through events. So we have what we call best place to care events that we do in each of our communities that we have really listened to our clinicians. So some are physician and APPs, with operational leaders together, so we can form network connections together. We also have heard from them that they'd love to bring their families along, and so we've done things that, like, some Top Golf or other places where we've had family events or baseball games, those types of things, where people are making connections not only through the individual physicians or APPs, but also through structured events. We also have recognition programs where people can nominate. And so and then we have an event, yearly in each of our divisions to really recognize those physicians and APPs that have, really, advanced not only in leadership, but, how they take best care of their patients, feedback from from colleagues. We have a lot of peer-to-peer support. So if we know that a physician is struggling with something, we know that no matter how hard we try to be perfect, there will be an outcome that is, less than desirable or something despite everyone's best efforts. And so we have a lot of mentoring, peer support, litigation support, those types of things, so that our clinicians make sure that they never feel that they're alone, that they've always got someone that has potentially gone through a similar experience as them that can partner with them, because it can get very lonely when you are handling something that is difficult. So we absolutely do that. We also, really believe in bidirectional feedback. So I send an email out once a week to our physicians and APPs, and there's a box in there to say, ask any question you have, and we make sure that we answer any of those and take the feedback that we have. And like I've already mentioned, we know that physician engagement is really strengthened when physicians and APPs see opportunities to grow, lead, and influence beyond their daily work. And so we support leadership development, like I said, mentoring, and then just learning through our Best Place to Care platform. And I think when we do that and we really have transparent and authentic communication, then that builds trust. And it reduces the noise that we know happens each and every day that can really, undermine that engagement.
Excellent. Next question. How can you implement system-level solutions to address the root causes of burnout? And Tom, why don't you start us off?
Yeah, Chris, I think you've been hearing from all three of us that we work in places where we have implemented system level solutions. And I think, to answer the question from my perspective is you have to do some basic measurement to address systemic issues. So I think you need to measure well-being or burnout reduction in a fashion that you can then focus on areas that are going to be the most important to the largest number of providers. And I think that's important. And once you have the data, then you become, it's not that it's easy, but you can focus on those things that might help the largest number of people. So we've been hearing a lot about the electronic health record. Obviously, that's a systemic issue for all providers to deal with the electronic health record. How can we make it efficient? How can we make it work for us? And that's one idea, but I think there are many others that when you talk about systemic issues, I think you have to look at the big picture and do some measurement. And then, in addition, you can look at local areas because our local providers have some different needs, whether they're peri-op versus outpatient primary care, that are a little different as well. So I think in the quick response to the question was, I think you implement system level solutions only after you make some measurements on what seems to be some of the drivers for the largest number of people.
Great. Tricia?
Yeah, I'm so glad you started there, Tom, because I think that's super important. And I have to say, I've been in this work for over a decade. And I've always felt like there's this conundrum in my head of how do you think about system level solutions given the complexity and variability of our teams? And I will say, even in our organization, when we break it down, for example, across primary care, there's wildly different experiences and well-being on different teams, even within the same system, in the same city. And so I think that one of the things that always comes up for me is, how do we think about driving grassroots solutions, grassroots level support? That is a system level intervention, but how do we allow our individual teams to kind of embrace that empowerment to figure this out, trusting that they're going to have answers that, somebody outside of that individual team is not going to be able to see. And so, what an emergency room group needs is very different than what a radiology group needs. And so, but what kinds of support are we providing as a system to allow them to tap into some of those tools and skills and support at that individual team level?
Susanna?
So first of all, I don't have a lot to add because my colleagues, really covered mostly everything. But I will say, that the definition of burnout, the definition of wellness, of value means something different to every single person. So to Trisha's point, you can have a group of 6 or 7 physicians in the same primary care practice in a certain area, experiencing the same workflows, the same AI tools, etc. And one person feels very valued and has less burnout, right? And others do not. And so I do think it is very important for us to continue to listen to our physicians and APPs, make sure we understand, how people want to feel valued, what wellness means to them. We also do have a lot of data and surveys that we use. We want to be very intentional, obviously, about not over-surveying people. And then what we do is, we put out a "you said, we did." So, we heard you. This is what you said. This is what we did about it. And if we couldn't do anything about it because it was something, so for example, like I said, we're a part of a very, very large healthcare system, and there's a lot of people that would love us to have a full child care right on site. Well, for lots of reasons, unfortunately, we're not able to do that, but we're able to explain it. And we do offer, emergency child care in people's homes if someone, if a child gets sick, through a service, but we're not able to offer like a daycare. So, so even when we cannot, offer to our physicians and APPs what they ask, we're very, very intentional about explaining the why. And people really love to hear, wow, I really made a difference. And I'll tell you, in our last survey that we sent out, over 70% of our physicians actually completed it. And that was a huge improvement over the year prior. And what that's telling us is that we're hopefully creating a psychologically safe space, first of all, that our physicians believe that when they bring something to us, they're actually listening to them. And that "you said, we did" was sort of an aha moment for them as, wow, we said this, and this is, what they're able to do in implementing this. And if we didn't, like I said, we explained the why not, so people don't think that it landed in a void that no one paid attention to.
And circling back to Tom, talk about measurement. How are you measuring well-being? How are you measuring burnout? Just go into the details on that.
Sure. I've been fortunate that I use a consulting group. It's called Chartis Burnout Solutions that does an annual wellness survey. And my program is for all employees. It's not just the clinicians. So it's a very large survey, and it's done annually. And that's been a godsend. And, the heart of that is to make sure that whether you use a consultant, whether you use free survey tools, which are out there, that they're validated, useful tools that you can compare nationally. So at the heart of ours, the Maslow Burnout Survey, as well as some of the Stanford survey mechanisms are used, and we have great comparisons. I think it was Suzanne who mentioned the AMA survey as well, and being able to be a part of their program and getting recognition, but also to have comparison data from your site. I think that measurement tool allows me to then go out and prioritize and not just try a bunch of things and let's hope something works. It will help me, it does help me focus and address those specific areas and also compare areas. I think it was Trisha who said also it's, sometimes even within a practice, it's very different. But I find the survey to really look at if regions are different, why are they so different? If two practices doing the same work are very different, let's dig a little deeper into why that is. And I think those are some of the opportunities we can take to build some of the agency that physicians need to feel, as long as we hear them. And as long as Suzanne said, as long as you show we heard you, And either we were able to address it, or we're attempting to address it, or we can't for these reasons. I think that feedback is critical.
Anything else on system level solutions to address root causes of physician burnout before we move on? Great. Let's move on to the next question. What are successful strategies for physician leadership development? And Tricia, why don't you start us off?
Yeah, so some of the things that come up for me with this question, first is just are we aligning our incentives for our leaders to participate in things like leadership development? And what I mean by that is, what are the existing incentives for leaders? Is there a possibility for aligning leadership development within that, but also time? So many of our leaders are very burdened for time trying to navigate complex roles. Many of them are still practicing clinically and are trying to operate as a peer leader in many ways, often, which is a challenging role. And so how are we kind of acknowledging the challenges in that and the time pressures and meeting them where they're at? The other thing that comes up for me is around this measurement and what are we expecting of our leaders, and is there accountability for their team's experience? That can be a little bit tricky because the leader can only influence their team's experience, but are we measuring that? Are we having conversations about their team's well-being and what sorts of things a leader can do to improve their team's experience? And I think the other thing that I see that can be a really powerful draw to leadership development is how it's done. So within the leadership development, is there an opportunity to build community for our leaders? So can we create some of those spaces where they can come together to discuss some of the challenges of the role and learn from each other, but also develop a support system for each other that may not be present for all.
Great. Susanna?
Yeah, so we've had a physician and APP leadership development program. I think for over 20 years, we have this. We're in the 20th year of our cohort for a physician and APP leadership sort of institute. We partner with our Wake Forest University School of Business faculty and also engage health system executives and senior leaders across the enterprise. I am privileged a lot of time to kick off a lot of this work and also participate in some of the graduation. So we have, several cohort programs. Like I said, we have a Physician APP Leadership Institute. We also have leadership mentoring, which I know I've already mentioned. And then we have sort of a development conference. It's been interesting to tie this back to, our earlier part of the conversation. As we've adopted AI technologies, clinicians actually have found that they have more bandwidth to start thinking about their work differently. And the idea of taking on a leadership role is much more appealing to them these days and what we've seen in the past. So when we open up these cohorts of leadership training, historically we may have had maybe, and I'm only speaking, right now for, the Charlotte area because this is where we started. But historically, we had, 40 or 50 people apply for these courses, and now we've got hundreds of people that are applying. So I do think that's a testament to, people are finding bandwidth in the work that they're doing based on what we're helping and supporting with AI. And we also want to make sure that our physicians develop obviously to their maximum potential, and as they do that they're very, very much attuned to the importance of culture and well-being, which ties in also to what we've been talking about. So it has been very heartwarming to me, and I tell you that the generation of leaders that we are growing that are going to be the future of healthcare is inspiring every day when I meet with several of these leaders that have gone through several of these courses.
And Tom?
Yeah, I agree with both of my colleagues on all those things. The leadership development I've been involved with for many years, and even I was the system chairman of emergency medicine for 22. I first of all applaud Tricia for stating how sometimes that can be a lonely position. That leader can be really by themselves and not part of the team because they're seen as someone different. So really key and really nice to use a bunch of clinical leaders to form a community on their own too. I think that's critical. But one thing I've found over the years is a lot of leadership development was focused on administrative duties, where how to do a budget, how to look at time and slot utilization. And it really didn't focus on how to keep your teams healthy and well. So wellness-centered, if you want to say wellness-centered leadership, wasn't a focus. So I think I felt a big difference in our leadership training within my health system when they invited wellness to be a part of the team, to look at what their plan was, what their education development program was, to really point out things like psychological safety and burnout and what to do to make that part of a leader's job. And one other thing we did now about 3 or 4 years ago, and we haven't done again, was do a leadership survey where we used the Stanford Leadership Index to do all of our chairmen and their direct reports filled out the survey. And it wasn't used for anything more than their own personal development for the chairman. And I found that to be a really useful tool. Number one, we were able to share the anonymous data, and it made that team of leaders, in this case it was chairmen, really look to each other and make some internal decisions on their own of some things they would like to have in their own leadership development program, and then carry that on to their colleagues who they believe are future leaders and do that. So I think the idea of a leadership tool for measurement to see how people are doing, and to use that as a tool for self-development, and you can even focus just on the individual with those, or look at things that the whole team might need to know. So if, all of the chairman's surveys showed that people really felt like they weren't getting enough communication, then let's focus on a way to do different communication modes and measure it again. So, a couple things that I said there. I think a measurement tool is great. And I think making sure your wellness leaders are involved in the leadership development program to make sure that at the heart of things is the way we want to keep our leaders healthy, as well as the leaders to keep a focus on keeping their colleagues well and healthy and less burnt out.
So I have a couple of follow-up questions. One's for Susanna. You mentioned having a culture of well-being part of physician leadership development. Could you go into more detail on that?
Yeah, so it's part of all of the courses, right? How to have, intentional conversation. I will always say that culture is what drives us. Culture is what helps, retain our clinicians. And so, seeing the value in how we not only, take care of our patients, obviously, but take care of each other, and making it part of the sort of the core principles, to be a good partner to each other, I think is critically important. So as we go through leadership development, sort of those crucial conversations, how to have them, how to give and receive feedback, right? Make sure that you're being, active listeners, making sure you're providing the tools to do that, I think it's critically important. And so within, a lot of the sort of the mentoring, like I've already said, trying to pair people up with mentors that share similarities, but also have an opportunity to learn from different people, I think, is critically important. And like others have said, we do have a lot of data from different surveys that we take in, want to make sure we're creating a sense of belonging is what we call it, that you have ownership, to your practice, to your specialty, to the organization, making sure that, we create a psychologically safe space so that people feel free to voice their feedback without any fear of any retaliation or any, anything like that. And I think creating that safe space is what allows people to feel very comfortable, bringing up things to us. And then we have, a lot of sort of advisory groups or governing councils and other committees where people come together and learn from each other. But I think, we've all said it, as we get bigger and bigger and healthcare gets more and more complicated, we've got to do our very best to make it feel smaller, to make sure, I think Tom said it really well, that, it's not a lonely business, that you have someone that has your back. And part of that is creating a culture of people feeling that they can, come to anyone, including their colleagues, with something and be hard and, not feel that, it's falling on deaf ears.
And Tom, could you expand on wellness-centered leadership and how you embed that in your physician leadership programs?
Sure, Chris. Wellness-centered leadership was a term coined by from a paper that came out of Stanford. Tate Shanafeld wrote a paper about wellness-centered leadership, and at the core of wellness-centered leadership was care about people always. And second part, it was an easy three-part triangle. The second part of wellness-centered leadership was building relationships between individuals as well as teams. And the third part was being a change agent, or someone who helps develop change and helps develop people. And I thought it was a very simple, unique, it stuck with me I forget, it's probably about 6 years old now. But so I used that as part of the training for leadership development to remind our leaders that, hey, as you're learning all this stuff, go back to the basics. And at first, are we thinking about caring for each other's always, right? And developing that community and those relationships. And then relationship building. I mean, our whole humanity is about building relationships, right? Both out of the hospital, in the hospital, at work, at home. It's building great relationships that keeps us there, keeps us going, keeps us engaged. So how do we encourage that while we're working, that place we spend so many hours every day? How do we build those relationships and keep them strong within the community? So it's those things that I recommend, and I have others who help teach into the program for leadership development that wasn't there before when we weren't really focused on wellness.
Let's move into some Q&A from the audience. First, I want to thank all of you for an excellent discussion. So we would now like to invite you in the audience to ask live questions of our speakers. As a reminder, if you are participating in the live program, to submit a question, click on the Q&A widget at the bottom of your screen. It may be open already and appear on the left side of your screen. Please note that your questions will remain anonymous and will not be viewed by other audience members. First question, is anyone using the EHR to flag potential workplace violence risks? And I'll open that up to anybody.
So we do have a huge program on workplace violence, and we, have a module that we all create, and we train our, all of our teammates, physicians, APPs to recognize it. I don't believe, though, that we have it embedded in the EHR. That doesn't mean we don't. I could certainly find that out. I don't believe that it's flagged within the EHR itself.
Anybody else want to tackle that?
Sure, Chris, it's Tom Campbell. We do have a program that's very large about violence prevention within the healthcare system. And we do have symbols within the EHR that have been created to talk about this is a violent patient or who has had violence in the past. It's been there for years in the inpatient electronic health record, as well as visual clues for those who aren't in the electronic health record, such as our dietary and environmental service folks who aren't in the electronic health record to know this is a potentially violent patient. So we have symbols that are out of the record, but also symbols in the record. And most recently, this past year, we've been able to create something for the outpatient facilities as well. So if someone is scheduling an appointment, they have a history, it's well documented, of violence, we have a symbol that can be put on so that even those outpatient sites can be prepared. And that might even be having security personnel that aren't normally there for that patient's visit. And it's long, complicated. We had to have legal get involved, but it's doable and it's possible. We've done it, and I think that our staff enjoys it, and hopefully it's been helpful.
Great. Next question. How can you make sure that your AI tools that are involved in patient care, like ambient listening, for example, are HIPAA compliant? Anybody want to tackle that?
We do ask every patient before we utilize it that we're going to be using this. We tell them what it is. We say that it's not part of the permanent record, that it's deleted as soon as it's signed off, those types of things. And that has, created a HIPAA compliant, mechanism for us. And so so that we very, very rarely have any patient that declines it based on, being nervous about it. But if they do, we certainly don't use it.
Anybody else on that one?
I would just add that we've, a lot of our sites have tried to ease the way of simplifying that conversation as well, with posted signs and handouts when people checked in when it was new about this is the why behind why we're using it. And so it made that initial conversation for the physician much more brief and smooth a lot of the time.
Same thing, Chris.
Great. I think we have time for one more question. One of the audience members is wondering what the key takeaways from this webinar should be, and I was wondering if one of you wanted to tackle that.
I'll start. If you don't have a wellness program, try and get leadership support to develop one, would be the first takeaway. I'll let my colleagues give others.
Yeah, I would agree. I would say that there's probably, like I said, there's probably nothing more important than this work. It actually, there's a huge business case and also a quality and safety case for, ensuring that our physicians are well taken care of, and wellness is important. I am very, very thankful that I'm part of an organization that absolutely believes in it and puts a fair amount of resources in it. But like I said at the very beginning, we cannot take the best care of our patients if we don't first take the best care of our clinicians and give them the tools and resources that they need. So I think a key takeaway is exactly what Tom said. Make it a priority. It will. You will see that, even within Advocate Health, our turnover for both physicians and APPs continues to decrease. It continues to be well below the national average. And I'd love to believe, I know there's other components that go along with it, but I'd love to believe that it's this work that is why people are coming to this organization and staying. So I think that is probably one of the key takeaways that I'd want the audience members to hear.
So that's all the time we have for questions today. In closing, please note that our next Winning Edge program on March 10 will cover the Winning Edge for resolving regulatory burdens. A live clickable link will appear at the close of this program, taking you to our registration page for the March 10 event. Remember to follow along all week for continued coverage on strategies for keeping your physicians happy by visiting our website, healthleadersmedia.com. I want to thank our panelists once again for an excellent discussion And finally, thank you to you and our audience for participating. We hope you have enjoyed today's program and look forward to seeing you during our next Winning Edge program on resolving regulatory burdens.